Well, hello and welcome to Chapter 12 in Patient Care, which is all about history taking. This is probably one of my favorite chapters only because I do not struggle at all with history taking. This is where you have your license to be nosy. So if you are nosy or inquisitive or what other adjective you would like to use that means you want to know details and you ask a lot of questions, this is the chapter for you. If you are super shy and don't ask a lot of questions and don't look for details, then this is probably going to be a struggle for you when you get out in the field. History taking is something that is absolutely vital to our imaging process. When we talk about this in Chapter 12, it starts on page 136, and they reference that you have to look at obtaining the patient's history as an interview. You're basically interviewing the patient for the radiologist. You are trying to be his or her eyes and ears, listen to what the patient says, and just so you know, in most instances, the radiologist will never have the opportunity to actually interact with the patient unless they're having an interventional exam. Then they will interact. But aside from that, everything that radiologist gets comes from you. Their history, the pertinent questions that you ask, the images, all is based on what you provide for that radiologist. Okay. Often as a professional, an RT, you are, like it says, the eyes, ears, and mouth of the radiologist, and having good history taking skills is essential on your part. You'll hear a lot of texts tell you, it's not a big deal. Oh yeah, we take history, but it's not that big of a deal. You know, somebody else can ask the questions, but realistically, the only one that can pass that information on to the radiologist is the person that takes the images, because you attach your history along with your images, especially with the digital system. You kind of upload your history, or you scan the paper that you write on, and it along with the images to the radiologist. So very, very important that you take an accurate, adequate, sufficient history for that radiologist. When they talk about the patient history process, you gather the information and it has to be accurate and specific in detail, if at all possible. Meaning you don't want to just get generalized answers. You want specifics. You want patients to guide you with exactly how do they feel, when did this exactly start. Localize where things are going on, and you having a genuine interest in what the patient has to say, being attentive, and an aura of professional competence can give patients a real sense of caring. And a lot of times when people know that you care, they really want to give you what you're asking for. If you're ever tried to tell a story to someone and you could tell that the patient could really care less, or not the patient, the person could care less what you're speaking about, and they're doing that, yeah, yeah, okay. You know they really don't care, so you usually lose interest in sharing that experience or that story with them. And the same thing happens with the patient. If they sense that you're not genuine or empathetic, if you're not really listening to what they're saying, they're going to shortchange you on the history, which is only truly shortchanging themselves. All right, because this is all leading to the diagnostic results of the image that you are taking, images. A lot of times the reason we need a history is because it helps the radiologist kind of focus their attention where it needs to be. I think they give an example in the book of saying that, you know, just saying that the patient's hurts is kind of general. It implies the entire hand, not a specific area. So when you take the hand image, even though you're taking an image of the entire hand, if you tell the radiologist that the patient complains of pain over the right navicular area of the hand on the palmar surface, and it's been for 3 days after they fell and caught themselves on an outstretched arm, that is pretty specific, and it gives the radiologist a specific area to look at. Not that they ignore the rest of the image, but it helps focus their attention on where the patient's complaint comes from. So hopefully that makes a little bit of sense to you. It's not just something, it's not some random thing that we have to do. We have to get history and, we get annoyed by that. You want to do that because you're trying to give the best possible patient care, and you're trying to get the best diagnosis for your patient. They talk about some qualities that we have as interviewers. If the patient is angry, the best thing you can do is acknowledge it. Say, I can tell you're kind of frustrated, or you seem a little agitated. Is there something I can help with? Or is there something that I've done to upset you? Or most of the time it's not you. Honestly, we're one of the first departments to actually spend any time with the patient. Typically they come in, especially if they're in the emergency room, the doctor will see them, the nurse will see them. They'll kind of do a quick evaluation and get tests going so that they can find out what's going on. But lab might come in and draw blood, but everybody that usually interacts with them is fairly quick. So when they come for radiology exam, a lot of times we have to change the patient. It might take us a few minutes to perform the exam, so we're the first ones that actually spend any time. And sometimes, depending on how genuine you are, they're willing to open up with you and express why they're frustrated, or maybe someone didn't treat them right when they checked in, or maybe it was the whole situation, like maybe they were upset with whoever they got in an altercation with, or maybe they're just frustrated because their insurance company, I don't know, was giving the registrar hassle when they checked in. I mean, it could be any number of things, but you acknowledging it is the best thing for that patient, because it helps to eliminate it. Respect the patient always. Be genuine. Don't try to fake it. They will see right through that. Empathize with the patient and their condition. Tell them, I understand what you're saying. I'm so sorry that you feel that way. I'm sorry you've been sick for a few days. That sounds miserable. Just empathize and let them know that you can relate to, or you can understand what they're going through. Patients have to feel the information they're giving is important. And the more attentive you are, then the more valued they feel. You do have to be careful, though, that you don't let them get off topic. You want to kind of keep them focused on the questions that you're asking. Some patients are really good historians. Like, you can say, so why'd your doctor order this exam today? And they'll just blah, 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 and tell you everything you need to know. Some patients are very hard to get a history from, and you'll say, why did your doctor order this? I don't know. Well, did you see the doctor? Yeah. Why did you go to the doctor? It was a physical. And did you tell the doctor that there was something going on and that's why they ordered this chest x-ray? No. So some people are more like that, where you're like pulling teeth to try and get them to tell you something. So you just want to do your best. You want to be kind. You want to be genuine, respectful, and a lot of times that'll help the patient open up. You don't want to intimidate a patient. How do you intimidate a patient? You can intimidate a patient by your looks. Your face can intimidate a patient. If you look like you could care less to be there, if you kind of have this, snarl on your face, your lips kind of curled, like, oh yeah, one more patient I got to deal with in this 12-hour shift, or your body language could intimidate a patient. There's a lot of things. I mean, I don't know. I feel like I tend to read people a lot. I read their body language. I look at their facial expressions. So you have to be mindful of what your face is doing, what your body language is expressing to the patient. You want to be attentive to detail and demonstrate accurate note-taking skills. I will tell you, I am left-handed, so a lot of times when I'm trying to take notes on what the patient's saying, my back will be to the patient. But I always tell them before I turn around, please don't think I'm being rude. I have to write, and I am a southpaw, so in order to do that, my back is going to be to you, but I don't want you to think I'm being rude. That way they know I'm not being a jerk and turning my back on them. I'm simply taking notes, because a lot of times when patients see writing down what they're saying, they perceive that as being important, and they want to give you more information. Have really good questioning skills. Just treat it like an interview, like it says, like, so why'd your doctor order this today? Oh, what's going on? How did that happen? Oh my goodness, how long ago was that? And do you have any pain with that? Or, I mean, you would do it just kind of like if your friend was telling you about something that happened to them the other day, and you ask questions, you kind of treat it the same exact way. You have to have multitasking communication skills, meaning you very well might have to write while you're asking questions. You might be thinking what your next question is going to be while they're finishing up the answer. Not to say you're blowing off what they're saying, but with what they're telling you, you're coming up with more questions that you'll need to ask. And you always want to maintain a polite, professional demeanor. Things like looking at them, making eye contact with them, smiling. Sometimes I don't think people realize what their face looks like. And we all know there's a term out there for when your face doesn't look like you're being very nice. But make sure that that's not the face you have on, because patients already don't feel good or they're in pain. And the last thing they need to see is you with a snarl on your face or looking like you absolutely could care less to be there. They already don't feel good, so that's the thing that they need to see. So we have to be mindful of those kind of things. As far as collecting the data, most patients understand the importance of a history, and they'll provide the information that you're requesting. Most patients understand that you're relaying that message to the radiologist or to a physician. The information needed by the radiologist is specific to the reason for the exam. That's where I'm saying, keep them on track. You don't want to hear about the 15 surgeries they had prior to this incident, unless it's all related. But you don't want to hear what happened to them 30 years ago unless it's related. You want to keep them on track. Never disregard anything the patient says, especially if it doesn't fit with the opinion you're forming about their symptoms. Now, as a new student, typically, or a beginning technologist, you don't tend to do that. You don't disregard what they say, because you're really not formulating an opinion about their symptoms. But as you work in the field, you start to realize when people describing certain things, your mind automatically goes to diagnosing them. It happens to all of us. If you have a patient come in that says they have a lot of low back pain and gosh, it hurts right here, and they point to the small of their back and they say, oh, and it just kind of goes right down my backside here, down the back of my leg, most people would think, oh, sciatica. And you start thinking along those lines, and then they throw something in with, and I've noticed I've been really dizzy when I get up in the morning ever since this started. Well, dizziness doesn't go with sciatica, so maybe you don't report that. That is not what you want to do. You never disregard what they're saying if it doesn't go along with what you're thinking, okay? And data collection needs to be documented precisely and clearly using the appropriate medical language. But I will tell you, sometimes a patient will describe what is going on perfectly, and there is no medical language that you could replace it with to describe what they've just said. So sometimes I've literally written patient states, quote, and I write what they say, because that lets the radiologist know this is what they're saying, this is their words, not mine, and this describes exactly what's going on. There are two types of data that we collect. We collect objective data and subjective data. One is not more important than the other. They are both necessary. But when we look at objective data, that is information that is perceivable to our senses. So things like vital signs is objective information. Why? Because I can feel their pulse. I can see them breathing. I can listen to their heartbeat when I'm taking their blood pressure. I can see the reading on the thermometer when I take their temperature. So objective information is perceivable to my senses. It's able to be measured. It's physiologic, signs that can be seen, heard, felt. You can touch them. Maybe you feel that the wound is really hot, or you can see that there's a lot of bruising or it's oozing something. That's objective data. Subjective data is just what it says. It's perceivable only by the subject, meaning the patient. It's their feelings, their pain level. Like you might see that someone's in pain, but you don't know, are wimpy and they just, they're in agony, but they're a wimp, or are they really, really stoic and they don't really show when they're in pain, but their pain on a scale of 0 to 10 is an 11. So pain level is something that only a patient can tell you where their pain is. The patient's attitude, the opinion of the observer, and it's subject to interpretation. Okay, so subjective data is subject to interpretation. So that comes from the patient. Objective is typically things that are about the patient, but that I can perceive with my senses. And like I said, not one is more important than the other. You need both of them in order to have, what was I going to say? A good history for the radiologist. Not just a good history, but in order for it to be accurate and adequate, it has to have both subjective and objective information. There are certain kinds of questioning skills that we are to use. We should ask open-ended questions. Now, what is an open-ended question? An open-ended question allows for description or a response. It's not closed-ended, would be a yes/no question. You don't want to ask that. Sometimes you ask some of those questions, like, do you smoke? No. Do you have a cough? No. But open-ended would be, well, what kind of problems are you having that the doctor ordered this exam? How long have you been feeling this way? Things like that, not just a yes/no. You want to avoid leading questions. Like you don't want to, if they say, oh, I've got a lot of low back pain. Oh, does it travel down your leg? Can you feel it in your backside? Does it happen just when you bend over? Those are leading. You want to let them kind of tell you what's going on. You want to facilitate a response from the patient, meaning you want to encourage them to elaborate. What kind of things do that? You smiling at them, nodding your head like you're understanding what they're saying, or, oh, right, yes, oh, go on, things like that. Just those little verbal cues encourage them to keep going. You want to stay quiet in order to give them time to think and give a response, but sometimes they get a little nervous if the quiet lasts too long. So you can always tell them, you know what, it's okay. You think about that. We'll start the exam, and if you think of it, you can just let me know. It's not a big deal. Sometimes you have to take that pressure off them because they start to panic, and then it makes it harder for them to remember. You want to use probing questions to focus in on more detail. Like if they say, do you have a cough? I do. How long has that been going on? Probably a couple weeks. And what kind of cough is it? Is it a dry cough, or is it a wet, barky cough, or how would you describe it? And then you use probing questions to gain more insight into what's going on with the patient. At the end, you want to repeat the patient's responses to clarify that you've gotten the information correct and confirm and make sure they don't want to add anything. And you want to kind of summarize it to verify that it's accurate. Meaning, if it took them 5 minutes to give you the history, but you could wrap it up in 3 sentences, that's what you want to do. Okay, so you've been having a cough for the past 2 weeks. It's barky, productive. You're bringing up yellow phlegm, mainly in the morning, but it persists throughout the day. Nothing is really helping, no medicines, and you do not smoke. Is that correct? That would be summarizing and verifying that you're accurate. All right, so those are some of our questioning skills that we have to make sure that we utilize and improve on as often as we can. What do the radiologists want to know about the patient's history? They want to know their chief complaint. I mentioned this once before. The patient's chief complaint is the main medical problem defined by the patient. Like, why did you go seek treatment? It helps to focus the clinical history towards the single most important issue. Like, what was going on that made you go and seek treatment? That is the patient's chief complaint, and that's what the radiologist likes to know. If you had to ask just one basic question to kind of start off the history taking process, the best thing you could probably say is, why are we doing this exam? Or why did your doctor order this exam? What kind of problems are you having that they ordered this? Something super general, non-leading, opening it up for the patient to tell you what's going on. Why are we doing this test today? What kind of problems were you having that the doctor wanted this done? That allows them to open up. And like I said, some patients will give you all the answers to all the questions you were going to ask, and you might never open your mouth. That's awesome. Some people, you might have to ask a few more questions and probe to get the answers, but that's a good general question to open up with. I can tell you what not to open up with is, so how are you doing today? It's human nature. It's just being kind. I can't tell you how many times I've said it, but as many times as I've said it, probably 80% of that time they've come back and kind of eaten my face off about, well, I'm not good or I wouldn't be here, or well, I'm not doing good. Why would you even ask me that? I mean, it's just common courtesy to say, oh, how are you today? Well, obviously they're there, so it's probably not a great answer, but it's just one of those things that I have I guess, a bad habit of asking. I don't mean to. Hold that thought. That was Roxy. She decided she needed to get in on this history taking. All right, the elements of the clinical history, again, the chief complaint, doctors tend to focus on this. It allows the patient to add more than a single complaint if it appears that there are multiple complaints valid, okay? So if they don't have one single thing that made them go to the doctor, but there's a few things, that's perfectly fine. As long as it's not a diagnosis, it's why the patient went to the doctor. So it's not going to be in fancy medical terminology. It's going to be in lay terms, like my gut was killing me, or I felt like an elephant was standing on my chest and I couldn't breathe, or something along those lines. Not saying that everybody talks like that, but it's not going to be, well, the epigastric area of my abdomen was feeling a bit rigid as I mean, they're not going to talk real technical like that. Typically, unless our medical personnel, then they might use a little bit fancier language. If you ignore all the symptoms except the most predominant, then you will miss other important clinical information. So again, don't pick and choose what you listen to. Try and listen to the whole thing, and try not to make any assumptions with that. There are called the sacred 7 elements of history taking. Okay, and a lot of times it's not that we have to get a complete medical history on the patient. Somebody else has already done that, but the sacred 7 are typically what are recognized in order to have a complete history for the exams that we do. Those sacred 7 are literally localization, chronology, quality, severity, onset, aggravating or alleviating factors, and associated manifestations. And those are on page 138. Real quickly, when you're trying to localize or have the patient localize, you just want to know specific area of pain or area of injury, somewhere that is not just, like a lot of patients will refer to their entire abdomen as their stomach. My stomach hurts. Well, your stomach is only one section of your abdomen, typically the left upper quadrant. So if they're pointing down on the right side kind of low and they say, oh, my stomach is just killing me, that's not their stomach. So we would have them point to it, and then our history might be something like patient complains of severe abdominal pain in the right lower quadrant. That would be what we would write. Chronology. Oh, and with localization, let me just say that if they cannot pinpoint an area, like sometimes patients will tell you, oh my gosh, my hip hurts so bad. Where does it hurt? I really can't put my finger on it, but it's just right inside. And you can also say that the pain is non-localized. Okay, kind of like a toothache. Toothache, you can kind of tell the general area, but you can't put your finger on exactly where it is. So that is a non-localized pain. Chronology is anything having to do with the time element of the history. How long has this been going on? When did this begin? When was the onset of it? How frequent is it? Is it every day, every other day? Anything with time. The quality is the character of the symptoms. All right, so it might be the color of blood. Was it bright red or was it dark in color? The consistency of the body fluid, the presence of a clot or a sore, the size of a lump or a lesion, the type of cough. Like I said before, a wet cough or is it a dry cough? Severity is the intensity or the quantity or the extent of the problem. Like how severe is it? How severe is that burn? How severe is that rash? Is it just in that one area or does it go down your entire leg? The onset describes what the patient was doing at the time the incident or illness occurred. Okay. Aggravating or alleviating factors, typically an easier way to say that. Does anything make it better? Does anything make it worse? Sometimes when people have a hard time breathing, they'll say, it's much better when I sit up, but man, as soon as I lay down, I cannot catch my breath. But if I sit up or I stand up, I'm good. So the alleviating factor would be to be upright. Gravity kind of helps. The aggravating factor would be to be in a supine position. And associated manifestations, that typically goes along with when you're trying to determine if all the symptoms go towards the chief complaint or if it's a separate condition. They usually give the example of a patient having GI symptoms, and is that part of their cardiac condition or is it separate from their cardiac condition? Because sometimes the two go hand in hand. So that's the associated manifestation. So I'm not saying you have to, know all these 7 and every time you go out, I need you to localize the pain. I need the chronology of your history. I need the quality, the severity, the onset. It's not things like that. It's those kind of questions that I was telling you. How long has that been going on for? And where exactly does that hurt? And what were you doing when that began? And does anything make it better? Does anything make it worse? Those kind of things are what you're going to ask. Okay, that's how you develop good questioning skills. As far as the patient history considerations, you want to make sure that the patient's history matches the requisition. Meaning, if they are ordering, let me give you an example, a good example. I remember one time I was in the ER and this patient had fallen and they fell on their right side and their right arm hurt. But the order came down and they ordered right shoulder, right clavicle, right humerus, right elbow, right forearm, right wrist, and right hand. Now that, I can't do it off the top of my head, but at the time I counted how many x-rays that would be to do the entire right extremity. And when they were giving me the history, I realized that most of the pain was concentrated in their wrist and it kind of shot up their arm. So after I listened to them, I ended up going down there and I said, I realize you guys put in this order, but considering the patient's age, this would be, I'll just throw out there, let's just say it was 16 images that we would have to do. And I said, they seem to complain of most of the pain, like in the wrist, shooting up their arm. So would it be okay to start with the wrist and kind of see what we're dealing with, possibly do an elbow, but just kind of go from there? Because I really would hate to do all these images on this, I don't remember how old it was. She was a female that remember she was relatively young, probably in her 20s, and the physician was like, oh, that's great, yeah, I wasn't really sure what to order, so yeah, that sounds good. She just said her right side, so I kind of ordered everything. And I'm not picking on the physician for that. Some doctors are really good and know what exactly we do. Some really don't have a clue what exactly we image. Sometimes they'll ask you, I don't really know, if I order this, is it going to get this area? And that's where you are a good team player and you tell them, oh, well, if we do this, that's what you get. But honestly, you order this and that might be a little bit better. So as you're in the field longer, they tend to look to you for, I guess, advice or wise counsel as to what to do for the patient. So we ended up doing that, and I believe the patient ended up breaking her elbow is what we found out. But she didn't have to have all those images and all that radiation, so that was a good thing. So you want to make sure that the history they give you matches the exam that was ordered or the requisition. Do the symptoms support the exam that was ordered? You want to verify the symptoms with the exam request. And when they start off with how would you describe the pain, notice it says localized pain versus general pain, like an all over pain versus just in this one spot. And then things you want to ask, like where did this take place? How long has it been going on? The duration. Is this something old or is this relatively new? Okay, and history taking is probably one of those things that you get better with it as time goes on. The more text you listen to, you hear how they interview the patient, you hear the kind of things they ask. In the beginning, you'll likely have to take history, just standing one-on-one with the patient, asking all of your questions and writing everything down. But as you get more accustomed to what you're doing in the field, a lot of times you can actually take history when you're walking the patient from the waiting room back to the exam room, or when you're wheeling them from the emergency department down to your department. You can ask these questions and get all your answers before you even get to the room. Our role as the interviewer is to be a good listener. Again, take accurate notes and record them appropriately. Get answers to those key questions that we are supposed to ask, which are related to the Sacred Seven. Always present a professional image. Make sure your posture is good. Make sure you are dressed appropriately. Just the way you carry yourself can present you as a professional with what you want, because you want them to respect you just like you're respecting them, and you want them to be able to take part in their history taking, in it to be a joint effort, not a struggle. All right. You do recognize that you do play an important role when you interact with the patient. Absolutely you do. In conclusion, consider the patient history as an interview. A complete medical history includes both objective, remember that's perceivable to our senses, and subjective, which is perceivable only to the patient. Demonstrate respect, compassion, and empathy for the patient's condition. Clearly identify their chief complaint and get all the pertinent information that's relative to the procedure. Look for that subjective information, like keep your eyes open and pay attention to what you see, what you hear. If you hear them coughing and it's that wet, barky cough, then, ask them, I hear your cough and it sounds kind of wet and barky. Is it always like that? Or, maybe they say, no, it's not ever like that. It's usually dry. This just started today. Present a professional image, take accurate notes. Never forget you are the eyes, the ears, and the voice of the radiologist with the patient, because whatever you gather as far as information is going with that requisition and those images that you take to the radiologist, who will likely never lay eyes on that patient. So your observations and your assessment of that patient are essential to help the radiologist diagnose that patient, and don't ever underestimate that role. Take that role seriously. There are a lot of techs that don't take that role seriously. That just reflects poorly on them. The radiologist is never going to complain because you got them too much information, but they absolutely will complain if you don't get them enough. Because even though this hasn't been said so far, realize that when that radiologist reads those images and takes that report and signs that report, they are putting their license on the line at that point, saying to the best of their knowledge, based on what they've read and what they're looking at, this is what they believe the diagnosis to be. So the fact that they're taking all that liability by diagnosing, and what are they basing it on? Your pictures and your history. So I don't know about you guys, but I don't ever want someone to put their license on the line for something that I've done that could have been better or that was less than desirable. So if you think about things like that, then that just makes you not only a great advocate for the patient, but it also lets the radiologist know that you care about what you do, you care about your job, you care about their job, which just makes you an excellent team player. All right. And that is the end of chapter 12 in history taking. So if you guys have any questions or comments or concerns, be sure to write those down. If they were specific to a slide, go ahead and put that information on there. And when we meet up, we will discuss and try and answer any of those questions. Thank you so much.